finding of this case. Mrs. 26-year-old lady presented with clinical diagnosis of HIV positive with theory of disseminated tuberculosis, dissemination to lymph nodes, abdomen, CNS, chest, with theory of pneumocystic cardiac pneumonia, and sickness. It was a partial atomic. Prospective noted that she was moderately built for age. There was mild increasing fluid capacity, pleural cavity releasing 200 ml of fluid, peritoneal cavity releasing 50 ml, and peristaltic fluid was getting diluted. Coming to the first order of interest, lung. This complex comprises of bilateral lung, weighed around 191 grams. Pleural surface was dull with a focal fibrillary sac. Cut surface of consolidation in the lower lobes of the lung. However, there was no miliary focus, infarct or abscess seen. Tracheobronchial tree was unremarkable. There was no ulceration or the situation. There was multiple enlarged lymph nodes. The cut surface shows this multiple whitish necrotic areas. Section examined from the lung show ill-formed granulomas. These granulomas were in the peribronchial region as alveolar parenchyma and pleural base. These granulomas show central caseous necrosis with occasionally lined by multinucleated giant cells, epithelioid histiocytes, and lymphocytes. When Thiel-Nelson stain was performed, it showed numerous these acid-fast bacilli. Like here we can see, it indicates high bacillary load. Apart from the granulomatous inflammation, there was other pathogenic changes in the lung. There was deposition of this fragile material in the alveolar duct as well as in the alveoli. This material was positive for the pH stain. Apart from hyaline membrane, there was also foci of this intra-arterial thrombi. So along with hyaline membrane and this intra-arterial thrombi, it indicates diffuse alveolar disease in exudative phase. Apart from granulomatous inflammation and diffuse alveolar damage, there was dense mixed inflammatory infiltrate in the alveolar parenchyma, which was based in alveolar macrophages and diseases. In view of this macrophage inflammation, modified Thiel-Nelson stain was performed to rule out any atypical mycobacterium. It was negative. pH and glucose stain did not highlight opportunistic infection like Cryptococcus, Toxoplasma, or any other fungal profile. Grams and grams of what was done did not contain any procedure. In view of the clinical suspicion of pneumocystis, ILC was performed for this year, and it was negative for the pneumocystic girovector. Apart from that, there were also foci of this intra-alveolar fluid collection indicating the pulmonary edema. Coming to the lymph nodes, there were multiple enlarged lymph nodes, including hilar lymph node, carinal lymph node, para-aortic lymph node, and mesenteric lymph node, size ranging from 1 to 6 centimeter in maximum dimension. And this is a section from one of these lymph nodes. It shows multiple this caseating necrosis, which was bordered by the similar granulomatous inflammation. There were these multiple well-formed granulomas which show central caseating necrosis lined by these multinucleated giant cells. When Thiel-Nelson stain was performed, it showed these numerous beaded acid-fast bacilli. Coming to the next organ complex, which comprises of a liver, pancreas, and kidney. Coming to the liver, it weighed around 1700 grams, which was heavy. Capillary effect was smooth, and cut surface does not show any nodularity or the space of a pineapple. Section examined from the liver show maintained lobular architecture with diffuse macrovascular steatosis. This is a higher part to show this macrovascular steatosis. There was ill-formed as well as a well-formed granulomas in the portal tract, periportal region, and the lobular parenchyma. And these granulomas show centrifugal necrosis and again bordered by multinucleated giant cells. When Thiel-Nelson stain was performed, it also showed these beaded acid-fast bacilli. Apart from the granulomatous inflammation, those portal tracts which does not show granulomatous inflammation were expanded were expanded because of this moderate lymphomononuclear inflammation. Special St. Mason trichome was performed to show that this expansion was due to inflammation and not because of fibrosis. There was no portoportal portocentral bridging fibrosis. In view of this chronic hepatitis, hepatitis B core antigen was performed, which was negative. CK7 was performed to show these normal bile ducts surrounded by this Duffler reaction. No cholangiopathy was seen. Apart from the granulomatous inflammation and chronic hepatitis, we also look for the other changes. It shows this dilated sinusoidal dilatation with Cooper cell hyperplasia. And at places, this Cooper cells show erythrophagocytosis, like we can appreciate here, the engulfment of these RBCs in this cytoplasm. When first gene was performed, it showed 4x4 cirrhosis. There was increased iron deposit in the portal tract macrophages, in the hepatocytes, and in the Cooper cells. Other than that, there were also centrizonal hemorrhagic necrosis. When reticulin stain was performed, it showed collapse of the reticulin fibers around the central vein. Here we can nicely appreciate the condensation of the reticulin fibers around the central vein. So apart from the liver, other organ which were involved by this tuberculosis was spleen and the bone marrow. Spleen weighed around 150 grams. Capsular aspect was smooth and cut surface does not show any focal lesion. Section examined from the spleen show maintained maintained white pulp and the red pulp. We can appreciate these well-formed as well as ill-formed granulomas. These are high pictures to show these well-formed granulomas with, again, Cation necrosis and multinucleated giant cells. However, when we performed the ZN stain, it was negative. Coming to the bone marrow, it again showed the similar granulomatous inflammation with caseous necrosis and the multinucleated giant cells. And when ZN stain was performed, it was positive for the acid fast bacilli. So apart from the disseminated tuberculosis, there was another significant finding, that was secondary hemophagocytosis, which was seen in all the reticuloendothelial organs like liver, spleen, lymph node, and the bone marrow. Here we can nicely appreciate the engulfment of this erythrocyte by the macrophages in liver, in spleen, in the lymph node, and in the bone marrow. So clinically it was suggested there was a thickening of the small intestine as well as the large intestine. We extensively looked for it, but we didn't find any mucosal as well as the wall thickening, and it was grossly appears unremarkable. Microscopically, the sections from the small intestine and large intestine does not show any tubercle pathology, and no viral inclusions were seen. Coming to the next organ complex, bilateral kidneys, bilateral ureters, and the urinary bladder, we can appreciate the aorta and it is the enlarged para-aortic lymph node. Cut surface shows similar morphology as we seen earlier. Grossly, there was also a benign cortical scar and the persistence of the fetal lobulation. The representative section from the benign cortical scar show interstitial fibrosis and the tubular atrophy. This is a higher part to show the interstitial fibrosis and mild inflammation along with the tubular atrophy. The glomeruli examined was largely unremarkable. Tubules show mild ATN changes in the form of epithelial shedding and the loss of brush border appearance. Section examined from the adrenal gland show adrenal hemorrhage, which is like we can nicely appreciate the hemocytonated macrophages. There were no granulomatous inflammation or fungal profile seen. Heart weighed around 426 grams. It was opened by modified Z-Nelson's modified inflow and outflow method. Grossly, it was unremarkable, and microscopically, it did not show any granulomatous pathology. Section examined from the stomach, thyroid, pancreas, ovary, skin, and muscle were largely unremarkable. Coming to the final diagnosis, this 26-year-old lady had pulmonary tuberculosis with dissemination to lymph node, liver, spleen, and bone marrow. Erythrophagocytosis secondary in liver, spleen, bone marrow, and lymph node. Diffuse alveolar damage in exudative phase and pulmonary edema. Chronic hepatitis, diffuse macrovascular steatosis, arteriolnephrosclerosis, adrenal hemorrhage.
Varunji sir.
I think there is something missing here because there were huge lymph nodes in the abdomen. Okay, you have shown that. Oh, okay, I'm sorry, I missed that. The second, which is a big surprise, is that on the CCT abdomen there was a lot of thickening in the bowel. I think it was was it in the colon or was it in the small intestine? Sorry. Huh? Ileocecal. So that is a little bit of a surprise because we probably, I think the unit's diagnosis in such a case would have been that this patient had a bowel involvement, or due to the caseous lymph nodes, which sometimes cause secondary involvement of the bowel, and there would have been perforation. The way this patient actually died, because obviously she had a huge burden of disease, but now probably whether hemophagocytosis killed the patient. Obviously, she had a huge burden of tuberculosis, but just to think of what exactly caused it, because there's no myocardial, at least, involvement here, you are saying. And so whether it was just septic shock and probably secondary bacterial peritonitis rather than, as we were thinking, perforation peritonitis.
Palla sir, followed by Jain sir.
Couple of things which are again intriguing in this patient. This patient never received ATT.
Sir, in hospital she received, but before coming to the hospital she didn't receive.
Before coming to the hospital she never received, and her total stay in the hospital was less than a week probably.
Sir, 3 days.
3 days. See, the kind of picture which you see in the lung, there is tuberculosis, there is, you have ARDS kind of a picture, no bacteria. Does happen in patients with tuberculosis when you initiate, ATT. But